to hear and to know me as a Black woman in the large mistrust in the medical community and see it happen to someone else who isn't even Black shows me that yes, there is racism in medicine. That is a given. But also there's a lot of ignorance in medicine, and there's a lot of arrogance in medicine. And the patient advocate said the best thing that you can do is listen to your patients. Dinner for one. I will take this do-rag off once I get to the venue. It is currently -2 degrees with a feel of -9. So I need to protect my hair underneath my hat. But I'm in Minneapolis. Let's flip this. But I'm in Minneapolis for a primary care and psychiatry conference. Am I applying psychiatry? No. But as a third year, it's my job to explore various fields of medicine in addition to networking. Network. It is so important. But let me get up out of here and I'll update you when I get there and on some breaks and stuff because it starts in 20 minutes and I need to call my Uber. I have sat through a few sessions. My favorite one is up next on ADHD. So like clearly I want to learn more about what pertains to me. So let's see if I could get some snippets, some tidbits during this session. And then obviously I'll debrief later. Excitement. All right. I think that so far I've been learning so much, but I am getting tired because it's been so long. Some sessions that I've really enjoyed have been the perinatal like mental health, and so like for pregnant patients, and also the impact that the pregnancy can have on the partner. So that was like a whole big deal. And then we had a lecture on antipsychotics. And I think right after lunch, we started with the meditation, and I actually really enjoyed that. It took me back to med prep days with Dr. Gina Paul. And before every class, and definitely exams and quizzes, we always started off with the meditation to like get your mind together. And I'm just like, love that so much. So yeah, I think we only have about like 2 sessions left, and then I'll be heading out to the airport to give y'all my real recap, because I'm sure I'll be in the airport for at least an hour before my flight. But I'm really happy that I came out here, and I look forward to doing more things like this in the future. But shout out to them for giving me a scholarship to come, because if I didn't receive that, I would not be here. I literally just saw a mouse in this airport, and that is freaking me out. Anyway, they didn't have a microwave, so eating my food code. We board in 10 minutes. That just means I will give y'all the rest of the tea on the conference once I get home and I get situated, because I am going to sleep on this plane because I am exhausted. But these Brussels sprouts, they smacking. All right. It's Christmas time. It's here. Okay, so first things first. I planned to arrive at 7:45 because the conference started at 8. And, you know, I'm not from there. And I was just like, I want to have a comfortable amount of time if I get lost in the building to find it. My hotel was 8 minutes away. Driver takes forever to get there. I hate when these apps say driver coming in this amount of time. They don't come in that amount of time, but if I cancel within 5 minutes, I'm gonna get charged crazy. Driver got lost. 8-minute ride turns into 20 minutes, and I'm just like, Lord, so help me God. Like, at one point I was like, this is the exit, and they stopped the car on the expressway. And we shouldn't have even got on the expressway. I'm not from there. And he was like, oh, this one. I was like, you passed it. How is it that I'm in the back seat and I hear the instructions and you don't? Be that as it may, when I got out the car, I said thank you, because I did get there safely, and that is what matters most. But the first session was on chronic pain, and I took several notes. So basically, there's the only commonality between chronic and acute pain is that they both share the word pain. They are not treated the same, and part of the opioid crisis in the healthcare system is providers not knowing how to properly treat patients. If you have chronic pain, according to this lecture, and there was a lot of research, everything today was research-based, should not be using opioids to treat chronic pain, because after a while, the brain, the way he explained was like the brain likes to maintain homeostasis. So with that, if you constantly using certain drugs or certain medications, the brain is basically going to recalibrate, and it's not going to be as efficient. So technically, opioids for acute pain, like when I got my wisdom teeth pulled, I had like a 7-day prescription of some hydrocodone. So that was with that. And let's see, we talked about how topical NSAIDs are actually good. Like topical capsaicin is also good because it depletes substance P. And I remember being on internal medicine and learning about topical capsaicin and telling my father about it. And then how buprenorphine is a better medication for opioid use disorder for those who have chronic pain. And let's see, the session that I was really excited about was ADHD, because I'm an ADHD girly. I'm what they'd like to say is a late bloomer, but no. I do think that in the session, more could have been said about why it seems like a lot of adults are just now being diagnosed. It was a PhD who was giving the information or giving that session, and at the end, the physician came in. So I did like the way they tag teamed me, right? Because the first doctor talked about the research base, right? But what she didn't do was go into more details about why there have been late diagnoses, but their hospital is doing a lot of restructuring of how to diagnose in clinic, and especially for children, because with a child, you don't necessarily need a neuropsych. You can literally go to like the school counselor and have them do it, or also it's the parents and the teacher to fill out the Vanderbilt. And so that's in the first visit, the parent fill it out, have the parent fill it out in the room. And then instead of giving the forms to the parents to give to the teacher, you can fax it right over to the school, just, to cut down on multiple people holding the paperwork. And ADHD is genetic, so a parent could also have ADHD, and then the paperwork just never makes it there. But she did touch on the fact that a lot of children miss the diagnoses, and how it seems like all of a sudden more people have ADHD, because in DSM-4, the cutoff age was 7. It was either 7 or 8 that she said, and then now it's 12. But then towards the end, when the physician came back and was talking about medication management, we also discussed how I've told y'all previously, my APRN told me about like when you develop coping strategies and you're masking for so long and you're not the typical presentation for ADHD, you're not bouncing off the walls all the time, people don't really suspect it. And if you're not struggling academically as a child, people don't suspect it. But like for me, I was very impulsive. I cannot sit through a long conversation. I am going to cut you off. We're playing games at school, like Jeopardy at school or Jeopardy at church. I'm definitely cutting you off before get to the end. And whenever people say like, oh, wait to the end before the question, you can answer the question, I'm just like, this is not fun, because my brain is constantly working, and then excessive speaking, which is why having a YouTube channel works for me, because, I just be talking to myself, and then y'all watch it. So like, it was resonating so much with me. But something that I didn't know, because I am familiar with some parents not wanting to start their child on a stimulant because, fear of addiction. But let me see, what did I write down specifically? Stimulants it's the most common treatment, and it has the most evidence on treating especially children, because in the future, if they're not treated, they can develop drug use later. And also you want to check out the child for other disorders, because there are a lot of comorbidities with ADHD, like a language disorder or developmental disorder or a learning disorder, and treating everything, because a lot of things can look like ADHD, so you want to eliminate the confounding variables, but ADHD does happen in conjunction with others as well. So that was really, really interesting to me. Oh, and here's some reasons to use a stimulant, because there's some good research on it. It can increase attention, decrease impulse control, or it increases impulse control, decreases impulsivity. You now form a better work ethic, more cooperative, physical coordination and remission of symptoms with stimulants. And she gave a really, really good analogy of, what was it? Driving a car, and without your medication, there are these pedals here, but you don't quite know when to hit the brake, so you might like slam on the brake or real jerky and jumpy with the brake. But once you take your medication for ADHD, now you have this control of knowing when to use the pedals and when not to use the pedals. So it's not like ADHD just fixes everything, but it allows you to drive more safely. So in that analogy, so it allows you to live a more safe life. So that honestly was the reason why I truly came to the conference. So I was like, oh, we're talking about ADHD in children or like adolescents and adults. Sign me up, we're there. And another session that I was really excited for was the perinatal mood and anxiety disorders. This was also presented by a researcher. And I felt like we could have gone a little bit deeper into Black maternal mortality rates and the impact that that has on mental health of individuals who've never been pregnant or those who have repeat pregnancies. But we kind of flew through those slides, and I'm not really sure if it was because we were short on time or the researcher wasn't too familiar with it. But obviously, as a Black woman, I was very interested in hearing more about that. And I'm also very passionate about reproductive justice initiatives. So anything that deals with pregnant people, it intrigues me. So I will definitely do a little bit more research there. But something that she said that was very eye-opening was, we always talk about postpartum depression. And it's not just postpartum depression. There are several mood disorders. There can be postpartum obsessive compulsive disorder, postpartum psychosis, postpartum, like various mood disorders, right? So not just depression, but also anxiety or delusions. And I was just like, wow, how am I more than halfway through my third year of medical school? Granted, I have not done my psychiatry rotation yet. That is what I am doing. And I am interested in completing an elective in like women's health and psychiatry, because a friend did that and said she learned so much. And I think it was like pregnant women in psych or something like that. But to learn that there is more than just postpartum depression. It's literally postpartum mood disorders. And depression is not the only mood that people encounter, right? Or the only mood that people have. But in addition to that, your partner can also experience postpartum mood disorders. And so when taking the history of a patient, your pregnant patient who's now going through postpartum life, you also want the partner in the room, because if they're supposed to be part of the support system, but they're also struggling, this is something that's very important for you as a provider to know. And taking a well thought out and thorough history, and something that they kept saying throughout the day, call on your other friends in medicine. If this is not your field, call on them. You know, like, if you are a surgeon, you definitely have a friend though that's like maybe a neurologist or a psychiatrist or an internist or a family medicine physician or a pediatrician. Like, calling your friends who are the experts. You don't have to figure it out all by yourself. You can always call in your team. So really loved that. And what we ended on was a patient perspective. It was literally a patient advocate who came to speak to us about their experience in the healthcare system from having experienced trauma as a child, with a close friend dying by suicide, and then being close with that friend's family and continuing that relationship well after their life had ended, and dealing with some mood changes themselves. And personally, they were misdiagnosed for years and constantly told like, oh, it's just anxiety and depression. And her friend who had passed, she was still close with his grandma, and the grandma was the one who told her like, oh, you should probably go get checked out, because I think that you may have a mood disorder. Was diagnosed with anxiety and depression for years, but was still having like these highs and lows. And psychiatrists kept saying like, oh, it's just anxiety and depression. She went back to talk to the friend's grandma. Grandma says, I think you might have bipolar disorder. Tells the psychiatrist. They continue to say, no, it's just anxiety and depression. It took almost a year for her to be properly diagnosed. And honestly, that session was very emotional to me, because when you talk about mental health struggles and also speaking about it in a room full of strangers, I think is very brave and very, I don't know, courageous to do. But to hear the patient advocate just going back through the details, at some points I feel like I could see the pain on their face, and I had to take some deep breaths to prevent myself from crying. And then at one point I would just let the tears fall, because to hear and to know me as a Black woman in the large mistrust in the medical community and see it happen to someone else who isn't even Black shows me that yes, there is racism in medicine. That is a given. But also there's a lot of ignorance in medicine, and there's a lot of arrogance in medicine. And the patient advocate said the best thing that you could do is listen to your patients. And I'm not just saying like, listen, like, oh, I heard you, but like understand them, like try to get answers for them. Maybe if you're still thinking that it's anxiety and depression and they're telling you that they believe it's something else, do some other diagnostics that you can. Like they said that previously when they brought up bipolar disorder as a diagnosis, the psychiatrist asked 3 things. Are you very impulsive, where you use your credit card and you like spend all the money in one day? Are you sexually promiscuous? And there was one other thing, and the patient advocate was just like, no. They're like, all right, well, it's not bipolar disorder. And patient literally said, well, this is later on, like talking to us. Out of 18 different things, they chose 3. I didn't have those 3, but what about the other 15? So it's important to do your patients a due diligence of taking a thorough history and physical and digging deep into the history. Like sometimes you do have to dig from patients and ask about the family history, the social history, the sexual history, just all of the things to create the biggest and the best picture. But all in all, I will say I learned a lot. I took all these notes on my paper from while I was at the conference, and it was great. And I think that no matter what field I decide to go into, learning these various things that are deemed psychiatry are important, because we all, like, yes, there are so many different specialties in medicine, but we're serving one person, one patient at a time. And people are multifaceted, and I could have a patient that has these things one day, and it's best to have like a little bit of information on things instead of like referring and always sitting out for a consult, because there's some things that you can do no matter what field you're in, regardless. And one other thing I want to share, there are 5 S's that she said in the perinatal mental health session, and it's safety, sleep, support, stabilizing meds, and structure. So when dealing with pregnant patients and in the postpartum phase, just remember that these are 5 things that you can use to ground yourself in the visit, or ground yourself when you're talking to someone that you know is pregnant. And also that postpartum mood disorders, they start during pregnancy. And part of it is the American system is really not set up for success. And there are a lot of things that people can't just take off 9-10 months while they're pregnant, let alone once they've had the baby, because you know, we're workaholics in this country. And if you are not the rich, you are the poor, and that means you have to do what you gotta do to get by. But I'm so happy that I went. I'm so grateful that I got a scholarship to go. And I'm happy I survived the coldness of Minneapolis, and I'm back in the coldness of Chicago. Let me know if there's something that I didn't mention from the session that you want to know. Oh, I didn't finish telling you all the sessions that they had: chronic pain, urine toxicology, ADHD, interventional psychiatry, perinatal mood and anxiety disorders, antipsychotics, mood disorders, and then ended with the patient perspectives. All in all, it was a great day. I was very honest with my feedback, but for the most part, I really did appreciate the information that I obtained, and I plan to take it with me as I go back to rotations on Monday to close out my surgery rotation and go into winter break. Catch y'all next time. I am going to take a shower and go to bed, y'all. I'm exhausted. Bye.